And you're both on mute, just so you know.
There we go. Thank you, everybody, for joining. I'm Scott Rossignol. I'll give Michael a chance to introduce himself in a moment. We are here to talk about the CMS Aligned Networks concept and how things are going so far. So we're going to take you on a 15-slide journey through that, and we'll be your guides through that. Michael, do you want to introduce yourself?
Sure. Hey everyone, Michael Westover. I'm the VP of Payer Partnerships and Informatics for Providence, and I'm currently at the ASDP conference where we're talking a lot about this topic. So I'm excited to be here.
Michael, are you able to make this and put this in the presenter mode or the
Yeah, I'll do that.
yeah.
There we go.
Great. All right. So I think we can just go through the agenda really quickly here. So we want to take you through what has happened so far, what activities have taken place to date through the work streams, the Slack channel, and talk about the pledges and the progress that CMS has made with a lot of different pledge signatories. We'll take another look at TEFCA and sort of compare and contrast and talk a little bit more about that, since that's been a topic for quite a while. And hopefully we can stop talking about that for a little while after this. We'll talk about what's working and also discuss some of the challenges that we're seeing with the current approaches and where we think some of these challenges are going to manifest or surface, and just generally what progress we're seeing as well. Okay. So Michael, chime in if I'm taking your slides here.
Go for it.
Yeah, okay. All right, so from the pledge's perspective, there are a number of different categories of signatories for the pledge, right? So CMS is categorizing different registrants, and registrants are given the opportunity to categorize themselves, and I think a lot of them are going in some of the wrong directions and getting pushed back into these categories that we see on the screen. These categories represent the different activities and sort of requirements of a given pledgee. So if you're a payer making a pledge, it's a lot different than a data network, for example. The website lists a number of those early adopters. That list is pretty short compared to what is in place today, though. CMS has indicated there's over 600 signatories now since the early adopter phase in what's on the website. So there's been quite a lot of progress towards getting additional folks signed up. And I would say some portion of those are participating in the ongoing activities and, joining work group meetings and such. Although we definitely need a lot more participation in certain areas, which we'll talk about more.
Yeah, and Amy Gleason today said there were up to 650 as of this morning.
Okay.
Yeah. My slide. So I'll take this one. So what might those CMS aligned networks look like? I think it's important to caveat that I don't think any official guidance has been put out, but there are the health tech ecosystem and CMS aligned network work groups have been meeting. And so I think they're starting to get a pretty good sense of what things will look like. But this could be wrong. So the first one is the networks will exchange FHIR data via APIs. Some of the other networks have had plans to introduce FHIR, but the idea here is that they wanted to start with FHIR and APIs. You can see here other networks rely on CCDAs primarily and are moving to FHIR. So I think that's one important thing where these networks will begin. The next one is there's an emphasis on record locator services, meaning if a patient's data is housed in multiple locations, there will be easy ways to find where my data is stored in those locations, so you can go pull the needed data from Michael Westover, whoever you were pulling data for. Audit logs, like who accessed my data when, is certainly part of this. I think just one of the big themes of the CMS aligned networks is they're very, very patient focused. I feel like a lot of where we're starting is with patients, and a lot of that also has to do with patients wanting to know where their data is. So introducing, where is my data is important for the CMS aligned networks, but we have a note here that they'll likely be extended to existing networks like TEFCA. And I think more than anything, when it comes to CMS aligned networks conversation, there's about this IEL2. And what that means is that instead of having, let's say you have an app and you want to log in and pull the patient data to that app. Let's say you want to use ChatGPT, and in the future, when you have the ability to use ChatGPT to pull down your own data and do analytics with it or get advice on what you should do from a healthcare perspective, instead of having to log into ChatGPT and then having to again log into all of your instances of maybe Epic or wherever your data is housed and log into your payer, you will log in once, and all of those organizations will allow you to pull your data down without having to log in each institution. So you'll just have to be authorized and identified one time, which I think is exciting. The next one is delegates will be able to access the data on someone's behalf. So you might have an app that's accessing the data for you. I work for a provider organization at Providence, we might have a vendor that's accessing data on Providence's behalf. That'll be a possibility too. There's lots of discussion around what a timely response to those data requests can mean. I've heard today that patients trying to access their data, sometimes it can take 20 minutes to pull the data down. And I think that people kind of feel like that's too much. I haven't seen a definition of what timely means yet, but this will certainly be a part of the discussion. And there are patient use cases all over the place. So a huge emphasis on patients pulling their data down and using that as the hub for data access. So possible rollout, they've talked about multiple phases. And I mean, Scott, you're welcome to chime in on some of this, but starting with point-to-point and manual registration. So trying to do it as simply as possible to get access to the data. And then moving to more dynamic registration or no registration through digital certificates. The CMS Aligned Networks are all about moving fast through different phases and trying to experiment with new things that haven't been done yet, or maybe have been done on a small scale and experimenting with scaling them. So it'll be interesting to see how this evolves.
Yeah, I want to touch on that point because I think there's a couple of interesting takeaways on this slide. The first being that the technologies that are deployed that we're discussing and defining as part of CMS Aligned Networks, like the audit logs or Fire Pub Sub or these patient access use cases, aren't specific to CMS Aligned Networks, right? So like with TEFCA, when TEFCA created an SOP, that meant that you could operate on TEFCA with those within those guidelines, that you could do a certain thing. But the audit logs are something that are not planned just for CMS Aligned Networks. When we do audit logs, the networks are going to do them for everybody. And it's going to just be something that's available, even within TEFCA, within the networks today, as well as within like the CMS Aligned Network concept. The other thing is that like we're sort of able to just define processes and move forward. We don't have to let perfect be the enemy of the good. I'm really in favor of the point-to-point connection and manual registration as a concept right now because we can do it. And what we need to do is we need to do things to show that they actually work and to prove the concept out before we really move towards that better option. So I really like the opportunity that CMS Aligned Networks provides in that it's a proving ground for different technologies where those technologies can then, if they're shown to be useful, be extended out to everybody else.
That's a good point. And I'll give you the quick example for Providence where, we have payers that we're working with and we want to experiment around doing some bidirectional data exchange for things that we need to manage our business and the patient populations we're jointly caring for. And this allows us to use Fire and APIs to experiment in that point-to-point manual registration before we try to scale it out. And I like that a lot too. Next slide.
Yes, please.
I believe there's something like 12 work groups going on with the health tech ecosystem right now, and you can see them on the screen. There's a bunch of shifting, and there are proposed new groups and proposed new pledges that are likely going to come up in the future. But my impression from the work groups that I've been attending are that there are 4 main work groups, and really the 2 big ones are the networks work group, where they're deciding like what could a CMS aligned network look like and how might that function and what are the minimum requirements. They're talking a lot about each of these has a minimum viable product. So for organizations that have pledged or thinking about pledging or are contributing in some way, what might it look like to participate in the network. That's been a hot topic in these, and I feel like there's going to be much more definition in the near future. We're going to talk a little bit about what we've talked about some of those things that they might look like. So how the networks are defined is a big one, and we talked about the phased approach on the previous screen. That's a part of the discussion, all of it. Then you have the kill the clipboard work group, which is more focused on patient access and getting patients access to their data, making life easy for patients so they don't have to log on to web portals. That's a big topic. Making sure that patients don't have to key in the same information or fill the information on the clipboard multiple times. And then there are subgroups within each of these, right? So we have patient consent as a part of this, conversational AI, how will that work? Diabetes and obesity prevention. And the same thing in the networks work groups. There are sub work groups that kind of feed into the main group that dive into some of the details and are creating some of the specifications, really requirements for that minimum viable product. And then there's an EHRs and providers work group that meets together. I think it's every other week, and then the payer work group too, where they're creating what is the minimum viable thing that the provider organizations need to do to comply with the pledges, and the payers are doing that too. I don't think the payers have a draft yet of what the minimum viable product looks like, but they're actively working on it over the next couple of weeks. So I'd expect something in the relatively near future about, for those that have said they intend to comply, what exactly do they need to do? It's a part of this. And I also want to mention again, just quickly, Amy Gleason has said a few times that there will likely be other sub-work groups that are created here, and there could be additional pledges that they ask folks to do. I think her vision is that this will be an ongoing, like living, breathing environment where we're innovating together and trying things and failing. Where some of like if you think of TEFCA, it's based on regulation and you have to get feedback and it's going to take time to do things. This is all about moving faster. Like what can we do by the end of March? What can we do by the end of July? So it's a lot about experimentation within these groups.
All these groups are chaired by the community, right? And it is the community that's doing all of the work too. CMS weighs in, provides some guidance, and helps us understand what they want to see. But generally, the community is driving all of this, which I think is pretty interesting. Compared to any other perspective, right? There are other conveners. The eHealthExchange is a convener, but the breadth of this is different than anything we've seen before in the U.S. from my perspective.
Yeah, and one thing, I don't know if it's a criticism or an opportunity, and I know they've been talking about it, so it's not a secret, but trying to see more cross-pollination among some of these work groups. I think there are a lot of network people in the network work group, but I feel like we need to have more payers making sure that whatever they're designing works for them, and provider organizations are like contributing in the discussion so that they make sure that it works for their industry. And the same with the kill the clipboard and other some of these other subgroups, making sure that we get cross pollination. I think is one area where I hope we see more.
Yeah, I mean, think about like 650 different groups, right, that are engaging in these discussions. If we could actually get that number, what we could see is like, respect to the Karen folks that are doing all the work, but they're also the ones that are leading the Kill Clipboard work group, right? And it's the same folks that are involved in that are currently involved in CMS, and like that's I'm not saying anything negative about their involvement. They're great people. They're all smart, but we need more. We need the community in order, because if the community all buys in, if you have 600 different applications all saying, yeah, this is how we're going to do it, that's just better in general than 40 people or 30 people that are constantly engaged in this, setting rules and then hoping for adoption. So I think that that's pretty interesting too. Like the idea of having these large work groups are just a way to disseminate technical requirements really fast to a larger group of people if it works, right? And I think in pockets we already see it working. In pockets we see some dysfunction or inability to actually like move things forward in a productive manner because there are other blockers or other problems that need to be solved. But I still think it's really cool that we can bring together a bunch of people and make decisions and actually get those implemented and see the outcome.
Yeah. And I want to say I was in a meeting today and someone asked a question, are there any testers? And there were some individual patients that have complex cases and patient advocates that raised their hands and said, I want to be involved with the testing. I love that. I love that the payers are very engaged in this, trying to make it work. I feel like there are many provider organizations that are engaged too. And I think we need more of all of it.
Mm-hmm. Right. So to start with a little bit of the discussion around CMS Aligned Networks versus TEFCA. First, I want to go to Steve Posnack's blog post. And, if you haven't read that, that's a great primer here. And it's actually kind of funny that different agencies have actually expressed different opinions in the federal government around what the difference is between these networks. So I'm not sure that they're all aligned in terms of where they want to head in the future and what they see as the value of each of these networks. So that is somewhat concerning from time to time, but also interesting to see. The ONC or ASTP is very, invested in TEFCA. And what you see from them is they're basically saying that TEFCA is the long-term approach. It is the rising tide, where data exchange on required purposes of use is going to be successful across healthcare payment and TPO use cases, as well as like research, government benefits. And if they are successful, that can really expand data exchange in a way that point-to-point agreements or really anything else cannot. The ability to onboard onto a network, make your data available, and obtain data from anybody for certain purposes of use is a very powerful use case.
Yeah.
CMS Aligned Networks are. Oh, go ahead, Michael.
Just quickly, that today that there was actually Amy Gleason, who is very much driving the health tech ecosystem in these CMS Aligned networks, and then Tom Keene, who's very much interested, ASTP, Posnack, they were on the stage today talking about this exact question. Like, do they work together? And I think they're starting to come together more and more over time. I think that what I heard from them is absolutely TEFCA is important. It's been growing a lot, especially since August of 2025. They're still absolutely supporting it. We're moving towards the TEFCA direction, but we are looking towards these CMS aligned networks for being innovative and thinking outside of the box and exchanging new types of data and bringing new types of partners. So I think, although I completely agree with what Scott said about there have been different perspectives and even discussion of tension between TEFCA and CMS aligned networks in the past, I feel like they're trying to come together more until more of a cohesive story.
That's a good thing. So attention aside, I think the idea behind CMS Aligned Networks as speedboats is really like the proving ground, like I talked about, right? Like 2 parties or 4 parties can get together and they can actually show that a use case functions. They can do it really quickly because they don't have to make sure that all of their I's are dotted and T's are crossed under like a TPO use case if you're just doing it in a BAA basis, right? Like there are easier ways to exchange data than required standards like the treatment standard on TEFCA. And so if we follow those faster paths, we prove something out, we show value to the parties that are engaged. We say, hey, parties, as a payer, as a provider, you can save this much money. We saw this happen in our pilot, right? That gives everybody in the industry the ammunition they need to move something forward. And it's not just dollars, it's also availability of data or, hey, this new data type that we started to exchange can really make a difference for this reason. So I think that all of that's really very great for the industry because we need these proving grounds. That's what Trebuchet is here for. It's the Da Vinci proving ground to show that something works and be able to kind of express the value of it in ways that others can understand. All right, so here's a little breakdown of how we see the difference between these networks. The CMS Aligned Networks versus TEFCA on the right. We try and talk through some of the different domains of interest here. The CMS Aligned Networks are really sort of that free market solution, right? This is the private sector that is pushing forward different concepts that's controlling the discussions and moving things forward versus TEFCA being really that government, define. The RCE is not government necessarily, but pretty close. And they're defining all of these rules and how data exchange looks in TEFCA versus CMS Aligned Networks being pretty much the opposite. The difference from there is really important or very, very impactful, right? So like TEFCA has these standardized network policies. They have standardized onboarding processes across the QHINs and QHIN participants. TEFCA has formal governance and the regulatory mandate. And all of these things lead to certain outcomes. I already talked about like the most important outcome, and that is required use cases, right? So TEFCA supports this required use case concept, allowing anybody to join the network for treatment. As long as you qualify, you can get on, you get access to data from anybody else. That required treatment concept is like extremely valuable in the sense that it's fast and it's easy as long as you follow the rules. CMS Aligned Networks have the pledge, but that does not make a required use case, nor does it make a HIPAA mandate, right? Like it doesn't allow us to say, okay, let's ignore HIPAA. CMS Aligned Networks is saying to do this. We still have to go figure that out. And so with CMS Aligned Networks, there are policy constraints. There are still issues with regulatory policy and legal that like we have to figure out or we work around, right? And that's what I love about this piece is the workaround, right? The BAA based exchange gets around all those issues, or just the ability for two parties to interact and talk about how they want to do something makes it a lot easier than having 50 parties at the table and the different opinions that they might bring. I think just to recap a couple of these others, a lot of questions, a lot of folks ask about how do I join a CMS Aligned network? So to answer that question, if you are part of one of the organizations that has pledged to be a data network, then you're probably already part of a CMS Aligned network, right? And what does that mean to your organization? I think we're going to talk about this later, but like go talk to that organization. Go talk to the eHealthExchange or Commonwealth or BeWell. Any of those organizations that have signed up to be a data network can help you understand what value you can get from them. And if you're a current customer, they'll guide you along and they'll want your business in this space as well.
Yeah. And one quick comment about that, signing up with a network. I've heard of a couple organizations that have been considering like becoming a network or maybe, and I'm not exactly sure how that'll all work, but the advice I hear is that if for organizations that would want to become a node on the network, that they would have to then connect to all of the other networks. So I think most organizations are going to connect through some type of pre-existing network that you're already a part of or that you will contract with. But I hear that there is a possibility that organizations could become their own network or could create a network.
Yeah, there are like non-networked, organizations today that are not networks, payers, for example, that might decide that they want to be a network and they want to just go get all the connectivity for themselves and basically act in that capacity. The networks themselves, what I haven't seen yet is discussions between networks as far as like, how are we going to contract with each other? How are we going to control each other's behavior? How do we know that somebody who is a bad actor creates their own network is not going to harvest data from us for the wrong reasons? Those kinds of conversations from network to network are going to be pretty hard. And so I haven't seen those happen yet. Maybe I'm getting to a different slide here, but I think like some of these things, they are shortcomings in our approach because we're trying to move fast and we're trying to just get things done. And what that means is we have to ignore some of these topics. But that doesn't mean that we want to expose or we're going to expose data. But what it probably means is that networks are going to be a little hesitant to say, oh, yeah, another network's participants can definitely access my participants' data. No problem. Now, there's going to have to be some onboarding criteria that we have to work through and some shared expectations.
Yeah.
All right. So from the what's working perspective, I think there are a few really important things that are working. The first is the marketing. That's kind of no surprise from the current administration, which seems to be pretty marketing heavy. They have a lot of events and they're showing demos and really providing like a lot of visual understanding of what can be in these demos. So I think that that's really great and that it helps build momentum as you see other folks that are actually doing something, even in a proof of concept capacity. These demos are available. You can go see the videos online, or you can even get a demo yourself from some of these different vendors. And then I think another piece is like the progression of pledges, right? So we're seeing more people pledging over time. We're seeing more payers coming into the space, which, for TEFCO, we don't have any payers signed up yet. So it's great to see payers coming in. I think, Michael, you could talk about the provider's perspective, and we're seeing some providers come on board. We need to see more, I think.
Yeah. I think I saw that there was some research that 80% of providers have indicated that they will likely participate in a QHIN, and there's been a lot of growth there. So I think a lot of they've seen a lot of intent for providers, but maybe they've been slow to act or kind of waiting for their EHR or for some like clear path forward before they act. Which, frankly, I would love to see providers step in and take more of a leadership role and kind of form the thing instead of waiting for the thing to happen to them. I think that'll work out better for the provider organizations in the long run. But in general, I see a lot of positive like openness to joining the networks, but maybe not driving it so far.
Yeah. And I think the last piece of this is that we are working towards certain deadlines, that we have deadlines in mind. The end of Q1 is an important one, seeing some production data exchange in whatever capacity. I think the patient access capacity is going to be a good one, but we want to move forward with production data exchange in other places too. And then there's a July 4th event that's also intended to showcase the progress from essentially last July when this was initially announced. I think the initial hope was that everything would be up and running and working perfectly. And, I have some skepticism around that. I think we're making good progress in certain areas, and we will see some production exchange, especially in July. But, these things are taking time still. It's not moving as quickly as one would hope, given these deadlines.
Yeah. I know that any organizations that step in and are at least testing, I know that there's going to be a lot of just I, I I've heard that no one's going to be punished for not being successful,
Yeah.
but those that are successful, at least in testing and trying and doing something, there's going to be a lot of positive feedback for those organizations that step in.
Yeah. So another component here that I think is really valuable is the technical definitions, right? So I work with the FirePub subwork group, and if we come out of that with a concept that is tested and even brought into production that allows for Fire publication and subscription, subscriptions first, and then the publication of notifications based on that subscription, like that's value to everybody, right? When we see that working, we're able to then move that forward and really create technology and in this capacity to get data that never existed before. So that ongoing work within those work streams, I think, is really important because it's creating artifacts that, even if something happens and they don't go live, those artifacts are valuable and they can be adopted and used. Those artifacts are from cross-community collaboration, right? They're not created by a single person. They're agreed upon by many people. And so I think we're just going to see progress regardless of, whatever we deem overall success of this concept. We will see certain pockets that are definitely going to work and get stood up and add new technologies into this ecosystem that don't exist today.
Oh, the next slide. So, one more thing about things that are working that I'm personally excited about, and this is some of the work that I've been deeply involved with, is that a growing number of payers are committing to using Fire and APIs and are participating in the health tech ecosystem. I think we haven't quite defined what it will mean for payers and providers to exchange data, but that is absolutely part of the conversation that's happening right now. And I think there's going to be a lot more happening over the next couple of months. But we're not talking just about treatment use cases here. We're talking about operational data exchange and what that might look like. So the meaningful data domains that are on the left-hand side, I seriously doubt all of these are going to be part of the, what it means to be a CMS aligned network and exchange data. But I think it's a good way to show that some of the conversations that are happening are leading to bidirectional data exchange between payers and providers. So if you look at member rosters, for example, these are member rosters that a provider organization and a payer organization are jointly managing through something like a value-based care contract, really being able to exchange data for any defined population using FHIR, using APIs. Humana is in production today, Regis is in production, Primera. So we're not just talking about testing, like this is FHIR data and APIs in production. There's CHPW, Aetna, and then there are other organizations that like we can't name now, but they are participating in the health tech ecosystem, and they're very interested in how can we do this at scale, because the way we're currently doing it, which is exchanging, hundreds of data formats across the country, is not scaling very well. It's hard to manage. It's incredibly expensive. Same for the claims data. There's a requirement for payers to exchange data with providers through the provider access APIs that are part of 0057F. That is, and I think this is a good forum for us to discuss how can we do that in a way that makes sense. I think there's a danger in the way that 0057 is set up now, and Blue Button and PDEX, and there's some flavors of it, and we're looking at ways that how can we standardize and do this in one consistent way that makes it easy for payers and providers to exchange data. We're also looking at clinical data to improve quality measures. We're experimenting with CDEX. We're also experimenting with DEQM, or at least having discussions about DEQM. What data do payers need to calculate their HEDIS measures, and how can providers exchange that data as efficiently as possible? So there's a lot of planning and discussioning happening at multiple levels there. And then we're also talking about financial performance on value-based care contracts and other financial performance, and then feedback on the patient data for gaps in care. So think about it like the provider is supposed to provide information to the payer so the payer can calculate those quality measures, but then the feedback on what the quality measure performance is and gaps in care for individual patients coming from the payer to the provider, there's a bidirectional component. So we're going to start with clinical data flowing from the provider to the payer and then getting that feedback loop. I think there will be a lot of opportunity for improvement, process improvement, incremental gains here. So I think this is one very interesting way that, payers and providers are actively working in the health tech ecosystem to improve operational data flows that are meaningful to their businesses.
I want to call out that not all of this work was done under the CMS Aligned Network umbrella, right, Michael? So
Much
like
of it
a lot of this, yeah,
through Trebuchet. I mean, was a lot
yeah,
of the work that we've done, and this is a Trebuchet meeting. That's been fantastic. But I think we're also having some of the similar conversations, or how can we, standardize some of the work that we're doing, or can we make this up? Should we make this a part of the pledge? And if we do, what would those check boxes be like to motivate folks? So I think it's like a logical extension of the work we're doing at Trebuchet.
yeah. And I think like the fact that the CMS pledge is really just like saying use FHIR for these use cases, right? Like, so claims details, that's essentially what the CMS pledge addresses. It says use FHIR for claims details, and provide those, from the payer back to the provider.
Yeah.
So the fact is that we can take existing real world use cases and we can apply those and say, well, actually, this work does work under the CMS Aligned Network concept. And I think that like that kind of generalization allows us to build a body of evidence faster. That something does work, right? That we don't need to implement like a new technology in order to get to where we want to go. That we could actually just do it today with what we have. And I appreciate that about this, right? Because we're in implementation guideline, we're often looking at the next best thing, the next new thing, and saying everything's going to be solved once we have that, right? And we don't need that. I think we need to focus in on what we have right now too.
Mm-hmm. Yeah. I know. I mean, I'm excited about this one and the opportunity. I mean, and another example would be provider access APIs. Payers need to expose data to providers for patients that are being treated by those providers and for populations of patients. So they have to do that. But if we can work together to do it in a way that actually meets the use case, that actually helps patients and helps our populations, I feel like there's a danger if we don't collaborate that you just check the box and do the minimum necessary to comply, and you end up creating something that there is no use case for, or that isn't as impactful as it could be. So I like this kind of interaction.
Yep. All right, so I want to talk a little bit about challenges, and Julie, your question kind of gets to this point. One of the things about CMS Aligned Networks is that there is no overarching authority. There is nobody establishing policy across the QHINs of CMS Aligned Networks. And so what that means is that there is no inherent trust. There is no sort of concept of trust in CMS Aligned Networks. There is discussion of digital certificates, although we haven't really arrived at how those digital certificates would be trusted. There is some policy work, but most of the work is really around technical integrations rather than around establishing, HIPAA authority for a certain data exchange. So, I think not having this top bullet point, not having trust certificates in policy hinders the networks in some ways. What it means is that we're not building the TEFCA of the future, right? And I think that that's a really important concept here is TEFCA provides trust, and trust uses certificates to provide identity and authorization for certain things to comply with policy, right? And so if we get rid of all of that and we say, okay, we don't have trust, but we're going to start with point-to-point agreements, and with a point-to-point agreement, you have trust between the two parties. You just don't have trust across the entire network, right? And that still allows us to do work, and it allows us to make progress, and then we can elevate that progress from there into, a TEFCA SOP, for example.
Wow.
Do you have anything?
No, just just along with what you said, I also think it opens up some opportunities to experiment with what trust relationships look like. I mean, there's a lot in the news, I think, that folks have seen about, Health Gorilla and Particle, and are there ways that we need to experiment with those trust relationships, point to point, or within a specific states? And I think it opens up an opportunity for us to play with some things that and figure out solutions, and then, like you said, expand them to the broader network, see how we can increment together.
Yep. Yeah, I mean, there's a concept of a digital identity certificate that would just not come from a private CA. So the idea that you could go out and get a certificate that does IAL2 identify you, I think, so there is work ongoing to move into this domain, although I'm still skeptical that we'll get a true outcome from this without really having top-down policy and top-down certificate authority that enforces certain onboarding requirements.
Point.
All right. So from a production readiness perspective, I think, we already kind of touched on this. Nobody's in production with CMS Aligned Networks except for maybe some of the patient access components. I guess that's not to say that Providence Humana, you all announced your integrations and that integration complies with CMS Aligned Network requirements. So there is some production readiness out there if we're really searching for it, but we're not quite there. We're not quite at the point where folks are really moving forward with a completely agreed upon and fully defined plan. So that's still in progress. And like I said, we're probably not going to hit that end of March date for having everything up and running with at least a couple of trading partners. And maybe we'll hit the July date where we see a good bit of production traffic. I'm skeptical that some use cases don't get off the ground at all, but I don't think that's a bad thing, right? Sometimes you experiment and fail.
Mm-hmm.
And just to address the comments, we'll get through all the questions at the end of the presentation. I'll touch on this, but Michael, I want to hear from you too. Provider participation is a problem in pretty much every domain that I've ever worked in from the healthcare perspective, because providers are, they have a lot of things going on, primarily treating patients. They don't necessarily have a lot of time to spend on concepts that benefit health tech vendors or QHINs or networks. But providers are still so important to this process. I cannot make assumptions about what a provider is going to say yes to from a HIPAA release of information perspective. I cannot tell what providers want from a workflow. So I think provider participation is a weakness right now. We need more providers. I think that's very common across the industry, though. What I'm most worried about, though, is that those providers that are pledging maybe don't know what they're pledging to and maybe won't actually do the thing that they're pledging. What do you think, Michael?
Well, I mean, I would say that I fully intend to fulfill the pledge. I'll just put it that way. I don't know about what all the other providers are doing. My sense is that there's also a lot of there are 12 work groups, and how do I function? And if I just go to the one provider work group, there's a lot of emphasis on just kind of flipping the switch on IAL2. Um, my sense is that for providers to be participate actively and be successful in this, we need to reach out to like specific organizations and individuals and say, here's a specific thing that we need your input on. Like if I say, right, a bunch of payers and providers we're going to get together and we're talking about operational use cases, and maybe we can create a glide path or phased approach for how we can experiment with and implement payer provider data exchange. Could we get your input on that? Providers are very interested in that and participating in those targeted conversations, but just asking them to join a blob of 12 floating, subgroups and try to figure out how to be helpful is something that it's going to be tough to convince very busy providers to do.
Yeah, and I think like we kind of bucket like providers. It's like, well, no, there's a government relations person, and maybe that government relations person has no idea what interoperability is, but they want to sign that pledge, right? Or there's the person, there's a role like yours, Michael, where you're really focused on getting data out of the system for payers and, for quality measurement. Um, so like I think when we think about providers, we need to break that down a little bit more too. And we need folks that are like the director of interoperability or like VP over payer interoperability or those kinds of roles are important, and we need to bring the right folks to the right conversations as well to get that feedback, and I don't think we're executing on that very well right now.
Yeah, agreed.
All right.
Uh, so questions, and I know, I mean, the ACB conference, some of these questions have come up, but maybe we could just start on the right-hand side. I, with the CMS aligned networks, we're going to be in situations, and I think Scott alluded to this, where you have one group of participants that has like one common agreement, and then another group of participants that doesn't have any common agreement or has a separate common agreement. And so the question is, how will one participant from agreement A that has signed agreement A be able to exchange data with someone who signed agreement B? And I think the answer is they won't, right? They'll have to figure out some other way to do a point-to-point connection or something like that to get the data. I've heard Kristen Valdez talk about trying to set up this infrastructure so that it's easier to trust other organizations and get data from them. But I feel like those are some things we're going to have to work through. There's also a question about, for CMS aligned networks, is this one giant network or many interconnected networks, or will each of the nodes have to? And I think there's going to become more clarity on this in the coming weeks and months. Um, so the next question is, can individual organizations participate in the broader network without hiring many, many, many vendors? I think there's a desire on some of the payers and provider organizations I've spoken to where, they would really like to lean in and kind of make sure that, they're participating in this and making sure they're following state and federal requirements for data exchange. And, they would like to have a seat at the table. And they would also like to say, all right, if I participate and give all of this fantastic data to the network, what data, I want to make sure I'm getting data in return. So I think those are totally reasonable requests that individual organizations might have. I think other ones might say, I'm just going to participate in a QHIN and they can pull whatever data they want. And I'm fine with other groups managing a lot of this. But I think there is a question for some organizations, like some of the payers I think Scott mentioned, where they've indicated that they want to have a seat at the table and manage their connections to the environment. I think that's a great question and area for CMS aligned networks to to play with. One is, what data domains and use cases are in scope? I think this is one exciting environment where if there's a data domain that's important to you and it's important to your business and to your patients, if you stepped in and said, I want to work with you as a part of a CMS Aligned network or health tech ecosystem and figure this out, there's a place for that. Like when I raise my hand and I say, hey, how are we going to exchange gap lists and DEQM data for clinical quality measures? I think everyone says, yes, if you have an opinion and you would like to weigh in and see what data should be exchanged at scale, there's a place for that. So I think if you have opinions, you should go. I think there's absolutely a need for leadership and folks that have opinions on what data domains should be exchanged. Maybe not for March or July, but ongoing, if this is going to be a living, breathing organization, this is where a lot of innovation could likely happen. I think there are questions about can this be done within the tight timeframes? What can we do, if anything, by March 31st? I think that's a relevant question. Will payers and providers join and actually begin sharing data? Or will they begin sharing data in a way, that really isn't benefiting patients? Like how protective are these organizations going to be? I'm curious to see. How much pushback? There's been a lot of discussion about, you know, I, I think you saw the DOJ was presenting at ASTP today or yesterday too, or yesterday in particular. And I think there's a lot of discussion around information blocking and any organizations that are perceived to be information blocking and like stopping those organizations from acting that way. So I think there's going to be a much stronger push in the very near future around that. And then how will we deal with the reality of data breaches? I think this is going to be an ongoing thing that CMS Aligned Networks, QHINs, TEFCA, everyone is going to be struggling with. There will be data breaches if we're going to be exchanging data at scale, but how can we minimize the impact of those, especially when we start having operational data and payment data that's flowing across the network, are questions that I think we need to evolve. And I think there's going to be a lot of discussion.
Yeah. These are great questions. I think, I would love to wave a magic wand and just say that if you are meeting certain security standards, that you are exchanging data on the network in good faith with partner, and that partner is misusing that data, that you're not responsible. I think there's some areas where the government could really step in and actually help us move these things forward. Because there are a lot of reasons that HIPAA gets in the way of data integrations, and maybe that's a good thing. From the integrations perspective, it's a blocker for me, but I'm not representing the patient privacy perspective, for example. So, I think these are great questions in the sense that if we could solve some of them, or if we could get guidance from CMS or OIG about some of these things, that could really help crystallize data exchange across the nation, regardless of which network you're using.
Yeah. I do know that if any organizations have examples of information blocking, I know that they're actively seeking. They want to have more information provided to them about those examples.
I have quite a few. All right. All right. So I think I'll take. What do you want, Michael? Do you want to do the what's good or what's not so good?
I'll take the positive. That's
okay.
Here. So I'll do. So we've seen a lot of cross-industry collaboration. I think that having payers engagement has been good relative to other networks that I've seen in the past. I think discussion of operational data and moving. I know we're in healthcare, so we start with treatment, of course, but the operational data and the payment data of just how healthcare works, being able to exchange that data at scale is really exciting to me. The focus on fast and iteration and moving the needle. I know that you could say this is maybe aligned with, the current administration, and the ability to show some success within the time frame of a 4-year presidency is important. But also, I like the idea of just moving fast. And being able to experiment and fail and try to not put things in legislation that haven't really been tested. I'm excited about minimum regulatory requirements and hurdles. I mean, I understand that there are pluses and minuses to this, but being able to just sit in the room with folks and say, what do you need to do? What data do you need to exchange and iterate without those hurdles is great. The focus, the alignment with TEFCA IAS, so this is exchanging data for individual patients is great. There's a huge, the emphasis on the patients I really like. I mean, being a patient, and I think we can all feel there's almost a shift toward a business to consumer approach, or allowing the patient to have more of a seat at the table and download the data and use it in the individual apps and access programs. I think is an exciting um, alignment here. And then the concerted work on pair provider data exchange. I mean, this is certainly an area that I care a lot about. And I think looking towards the payers and the providers and not just making interoperability happen to them, but actively asking them to have a seat at the table is something that I like a lot about the CMS Aligned Networks.
Right. On the less positive side, I think the one of the things that I'm most worried about is human nature here. I think the private sector leading use case definition means that certain interests are going to be prioritized over others, and that's natural. I'm not, pointing fingers. I certainly do it in my own role, right? I want to prioritize the eHealthExchange's interests where I can, in discussions to ensure that our use cases and the way that we exchange data is acceptable. So that private sector leadership, though, it essentially enables creation of certain barriers to entry for new organizations and allows incumbents to gain power. So that can be tough. And I think that we need to find ways to combat that. One of the best ways to combat that is to make sure that patient advocacy is front and center across all of these technical definitions, and that patients are really signing off on these concepts. One of the things I worry about for IAS is that we're going to get locked into this concept where if a patient wants their data, they have to use an application that is signed on to one of a couple of networks. And that application being signed onto one of those couple of networks has to pay a lot to gain access to connectivity. I don't think connectivity should cost money. I think that it should be commoditized to the point where it is free. And we've been making progress towards actually making connectivity free so that an application can get up and running and be able to get payer and provider data from those sources directly without paying. So I think there's some concern there around the private sector kind of bringing use cases towards their own revenue share or models. And I think that that's a natural thing in life, and that we can get around it and make sure that it doesn't negatively impact stakeholders in the right ways, as long as we're careful. I will also say that I think that we need to make more progress on certain use cases. I'll say it, payer provider interoperability needs more progress. We need to see more pilots. We need to see more work go into that space. In fairness, the payer work group kicked off only a month or so ago. So it hasn't had the opportunity to do a lot of work. I think we're still working on how we structure that to make decisions. We don't have very many providers at that payer work group. So how do we really get payer provider agreement in a payer only work group? So we have to figure out some of those problems in order to be able to advance use cases. With the patient access use case, like, everyone's a patient. We can all kind of advocate for ourselves. And so that one it's a little bit easier from my perspective to get agreement, although there's been a huge amount of work that's gone into it. So I shouldn't downplay that. But the patient access use case is making progress, is still really great progress. And I'm very appreciative of that. I just think that, payer provider interoperability is very top of mind right now, and I want to see it moving. And I want to see it moving in the right direction so that 2027 rolls around and folks have a great plan in place already that they are able to execute on and get connectivity and do the things that they need to from a quality measures, prior auth, and provider access standpoint.
Yeah, that's great. And one area I just want to double click on is that the cost thing that you mentioned, I think, is so relevant, because I saw in HTI5 how you can charge reasonable costs for data access, but defining what does reasonable mean for an organization that has the data and no one else has the data. It's the only organization that has access to it. It's just, I'm curious to see how that will evolve. And it could have a big impact on me as a patient and as an organization. So this is the last slide about how to meet the spirit of the pledge. There is nothing official here. We're just looking at, trying to read the tea leaves and see where things are going. So I expect to see more clarity on this in the future. But for payers and providers, I don't know. Would you like to maybe, Scott, handle the vendor side and I can do the payers providers one? Does that sound okay?
Sure.
Yeah. Um, so for payers and providers, I think determining that you will allow patients to easily extract their data, I think, is a huge part of the pledge. This, at least in the early stages, there's a huge emphasis on allowing patients to access their data. And part of that means allowing IAL2. I mean, is a huge push. I mean, the first thing that I hear when anybody says, what do payers and providers need to do? It's allow. I mean, right now, payers, for example, already have patient access APIs. And I think this is you have those APIs, but make it easier for patients to access those APIs. Just because you have them, like, doesn't mean the patients will use them. We want to make them really easy to use through IAL2 and AL2 so that folks can get access to that data. The next one is like use Fire and APIs for data exchange instead of the multi-tabbed ugly Excel spreadsheets and the other ways you're exchanging data. Use Fire and APIs. The next one is engage with your existing network or join a network. Providers are likely already participating in some kind of network. And I think payers figuring out their network approach or how they're going to participate is very important. Um, and if you, I think what's going to happen is you're going to have to join some kind of CMS network. The next one is bring in legal and compliance to ensure HIPAA protections. I think being thoughtful, not just like blindly trusting and signing all the paperwork and just allowing your data to start flowing out of your organization is important. Be thoughtful about what participation means and are you getting like you're providing data, asking that the data that you need in return is coming back to as a part of these discussions is a very reasonable discussion in my mind. And then the next one is adopt digital identity tools. Any kill the clipboard is a massive part of this. And turning on the tools within your EHR environment, allowing those to work and experimenting or trying to at least create a plan for digital identity and how you're going to let, folks get information from their payer at the site of care, that kind of thing will be very important.
All right, we're pretty much at time. Vendors, you see the bullet points, go out there and make some money, right? Like go create your product and do the right thing for your customers. And this is an opportunity to figure out what's the right thing and create some differentiated products that customers want to buy and use.
Yeah, did we answer the questions? I can't see them on my screen. Did we get to some of them as we talked?
Yeah, I think we could take a minute here if anybody wanted to chime in, ask questions live, or drop them in the chat. Otherwise, we are at time and appreciate everybody joining.
Yes, thank you.
Thanks, everyone. We'll be sure to make the slides and the recording from today's call available in the meeting minutes. Appreciate you all joining, and thank you, Michael and Scott, for your presentation. Have a great afternoon.
Thank you.